Hi everyone, welcome back to Game Pharmacology. In this session, let us discuss about pharmacology important MCQs. So welcome to which is required to produce the effect, maximum concentration which is required to produce the effect. So here the time for peak plasma concentration Tmax indicates what? It indicates the rate of absorption. The correct answer is the rate of absorption. So next, moving on to the sixth MCQ, that is the bioavailability. So very easy to remember the bioavailability. So what does bioavailability tells about? Bioavailability will tells about it is the fraction of drug. It is the fraction of drug administered that reaches the systemic circulation. Here very important point is in an unchanged form. So here let us see the options. So the option A is the amount of drug that reaches the systemic circulation. The option B is drug metabolized in liver before the drug reaches the systemic circulation. The drug metabolized in liver after the drug reaches the systemic circulation, and the maximum by rectal route. So bioavailability is not maximum by rectal route. So the correct definition here is the appropriate is the option A, the amount of drug that reaches the systemic circulation. So please remember in an unchanged form. So the 100% bioavailability is seen with the which route? Can you guess it? Yes, all of you might have guessed the correct answer. It is intravenous route has got the 100% bioavailability because it directly reaches the systemic circulation. Whereas the low bioavailability among the routes is seen with the oral as well as the rectal route. So how do you represent the bioavailability? Again, this can be asked in your exams. So it is represented by a letter F equal to area under the curve for oral divided by area under the curve for IV route. So which are the two important factors which governs the bioavailability? So bioavailability will depend on two factors. One is the drug absorption. One is the drug absorption and the first pass metabolism So is that clear with respect to bioavailability? Okay. Next, moving on to the seventh question. That is the branch of pharmacology that deals with the medicinal drugs obtained from plants and other natural resources is known as. So it is a direct question. So very easy to remember. It is nothing but it is the definition of the pharmacognosia. It is a study of medicinal plants. It is a study of medicinal drugs which are obtained from the plants. So what do you understand by pharmacogenetics? It is the study of genetic variability. It is the study of genetic variability for drug response. So they are going to see what are the genetic variability which leads to drug response. So what do you understand by pharmacogenomics? So it uses the genetic information. Pharmacogenomic uses the genetic information. For what purpose they will use genetic information? To choose the drug as well as the dose on individual basis. So please remember, on individual basis So the individual genomes are studied and they're going to choose a drug and dose appropriate for the genetic information. So next, coming to the pharmacopoeia. So pharmacopoeia, in easy way to remember is, it is nothing but that it is a large book or a big book or a dictionary which contains the information. It is the book containing information. What information? All information related to the drug production. So with respect to the what is the physical nature, what is the chemical property, so what are the ingredients you need to mix it. So all this information is required for drug manufacturers. So if they use the information from the book, so they have given some names. If it is from British Pharmacopoeia, it will be written as BP. If it is from Indian Pharmacopoeia, it will be written as IP. And if it is a US Pharmacopoeia, it is written as USP. Is that clear? Okay. Fine. Next, we'll move on to the next question. That is the true statement regarding the first order kinetics is. So please remember here again, two things are important. So you need to remember two things. What are the two things? One is we have a first order kinetic and we have a zero order kinetic. So what do you understand by first order kinetics? So let us take up one by one. So first order kinetic is, there is a constant fraction of drug is eliminated per unit time. And what will remain constant here? So two things are constant here. One is the T off will remain constant and the clearance will remain constant. And here the plasma concentration will be proportional to the elimination. So the elimination is proportional to the plasma concentration, whereas on the other hand here with respect to the zero order kinetic, the constant amount of drug is eliminated. What happens to the T off? The T off will increase, whereas on the other hand the clearance will decrease. So here the plasma elimination is independent of plasma concentration. Please remember, the rate of elimination is independent of plasma concentration. So let us see, they are asking about the first order kinetic. The rate of elimination is independent, so it is zero order actually, this option, zero order. So the constant proportion of plasma concentration is eliminated, constant proportion of plasma concentration eliminated per unit time. Off-life increases, so off-life increases with respect to the zero order kinetics. Clearance decreases, clearance is decreasing, it is zero order kinetics. So the option left out is it is the constant proportion of plasma concentration is eliminated per unit of time. So this is your answer here. So this is the first order kinetic, where there will be constant proportion of plasma concentration is eliminated per unit of time. So next, coming to the ninth question, that is at toxic doses the zero order kinetics is seen with, zero order kinetics. So please remember, you need to remember the mnemonic with respect to the zero order kinetic, that is the watt power. So W stands for your warfarin, H stands for your heparin, A stands for your aspirin, one more A stands for your alcohol, T stands for your theophylline, P stands for your phenytoin. So P stands for your phenytoin. So this thing you should remember. 0 watt power, 0 watt power, 0 watt power, which you should need to remember, Is that clear? Okay, fine. So here the answer will be, which is the option here? So the option here is, you have, which is the option which is matching here? It is your phenytoin. So phenytoin will follow the zero order kinetics. So here we have a phenytoin. So the answer for this is the phenytoin. So next we'll move on to the 10th question, that is elimination of after 3 half-lives in first order kinetics. So what will be the elimination after 3 half-lives? So initially there will be 100%. After 1 half-life there will be 50%. After the second half-life there will be 25. After this there will be 12.5. So they are asking elimination. So this is what remaining. This is the remaining content. They are asking the elimination. So here 50% will be there. If you add this 75%, and if you add this it will be, so elimination after 3 off. What will be 3? This is the first off, second off, third off. So after third off, what will be the concentration which is eliminated? It is your 87.5% will be eliminated from the body if the drugs follow first order kinetics. So majority of the times the drug will follow the first order kinetics. So next, moving on to the 11th MCQ, that is a non-competitive inhibitor of an enzyme. So for this you need to remember 3 very important graphs. So let us draw it. Okay, fine. This x-axis will represents the Km, and y-axis will represent what? The Vmax. So if you plot a graph, so this is the constant one, this is the competitive inhibitor, and this will be your competitive inhibitor example. So next, let us see what happens here. Okay. So this is the example for competitive, this is non-competitive, this is uncompetitive. So here they are asking about non-competitive. So here the Km is same, but what happens to the Vmax? Vmax is decreased. So here what happens to the Km? The Km is increased. What happens to the Vmax? Vmax is same. So here you can see that non-competitive Km is same, Vmax is decreased. So the answer here is the Vmax is decreased. Vmax is decreased. So this is the answer. So here the increase in Km with no or little change in Vmax is the example for competitive. This is the example for competitive. Here we have a decrease in the Vmax, decrease in the Vmax. Is that clear? Okay, fine. Next, moving on to the 12th MCQ, that is, all of the following drugs causes hemolysis in patient with G6PD deficiency except. So please remember, always try to read a question completely and understand it. So many times you are going to miss this exception part. So usually the primaquine will going to cause hemolysis, yes, chloroquine will cause hemolysis, and the quinine will going to cause hemolysis. So the option here is the correct answer is the pyrimethamine exception. So primaquine, chloroquine, quinine, even nalidixic acid, nitrofurantoin, all will going to cause the hemolysis. Dapsone, even the dapsone will cause dapsone, nalidixic acid, nitrofurantoin, all this will cause hemolysis in case of G6PD deficiency individuals. Next, moving on to the 13th question. So all of the following agent act by intracellular receptors. Please remember, intracellular receptors. They have asked again the exception. So intracellular receptors, as you know, they are the nuclear receptors. There are other name for nuclear receptors. Again, they are divided into cytosolic and the nuclear. So in the cytosolic, you have a corticosteroids and you have a vitamin D. Here you have got the paroxysmal proliferator activated receptors. You have got the sex hormones. So which are the sex hormones? You know, this is the sex hormones. You have got estrogen, progesterone and testosterone, and you have got vitamin A here, vitamin A and the thyroid hormones. So all of the following belongs to, this is the nuclear receptor, again this is the nuclear receptor, and this is the intracellular receptor. So the option exception is the insulin. Insulin will belongs to tyrosine kinase. So here you have a growth factor, insulin like growth factor 1. You have a JAK-STAT mediated response. Here you have got prolactin, you have got interleukin, you have got growth hormones, you have got cytokines. So nuclear are the slowest acting receptors, whereas the ion channel mediated, which includes the GABA A, you have glutamate, 5-HT3 and nicotinic. So these are the fastest acting receptor you should remember. So next, moving on to the 14th MCQ, that is regarding efficacy and potency of a drug. All are true except. So let us draw a graph here, again a graph. So if you draw a graph like this, okay, so this is the x-axis and this is the y-axis, and this x-axis will tells you about the amount or the dose. Amount or the dose. The y-axis will tell you about the response. So the amount of dose will correspond to the potency. It is the dose which is required to produce the optimal response, and this response is nothing but the efficacy. So the height will tell you about the efficacy. The distance which is moving will tell you about the potency. So which is more potent? Which is nearest to this side? So this is more potent. So if it is A and a B, the drug A is more potent than drug B. What about efficacy? Drug A is equally efficacious to drug B. So this you should remember. Again they have asked the exception here. Exception. In clinical setup, efficacy is more important than potency. Log dose response curve, the height of the curve will correspond to the efficacy. Yes. So we are talking about this height. Height of the curve corresponds to efficacy. Effective dose 50 of the drug corresponds to the efficacy. And drug that produces similar pharmacological effect can have a different level of efficacy. Yes, it can have a different level of efficacy. So ED50 of a drug corresponds to the efficacy. In a clinical setup, the efficacy is more important than the potency. So what is ED50? It is the effective dose. So please remember, they are talking about the effective dose. It does not correspond to the efficacy. ED50 will mainly correspond with the potency. So the exception answer is, this is the exception. So it corresponds to the potency, not the efficacy. So this is the correct answer here. So next, moving on to the 15th MCQ, that is a true statement regarding the inverse agonist is. So let us plot a graph here again. Okay. Let us see which are all the examples for this. So this is the example for the agonist. And this is the example for antagonist. This is the example for partial agonist, and this is the example for inverse agonist. So what is happening with the inverse agonist? So there is a affinity. So if you plot intrinsic activity, it has got affinity, but intrinsic activity is between 0 to 1. 0 to 1, or it is actually the 1. It is 1 for agonist. What happens to the partial agonist? The intrinsic activity will be between 0 to 1. So this is 0 actually. This is positive side 1. This is the negative side 1. So what happens to the antagonist? The intrinsic activity will be 0. Here the inverse agonist, the intrinsic activity will be negative, 0 to minus 1. 0 to minus 1. It will be negative. So here it produces the response. Partial agonist will have a submaximal response. So this is the example for the partial agonist. Binds to the receptor, it causes no action. It is the example for antagonist. So binds to the receptor and causes intended action. It is the example for agonist. So here we are asking the question on inverse agonist. So the answer will be, here inverse agonist is, it binds to the receptor but causes no action. So there is no action. No, sorry. This is actually the opposite action. Sorry. Okay, fine. So this I have marked as wrongly. So binds to the receptor but no action, it is antagonist. Binds to the receptor, it produces opposite action. It is producing the opposite action to that of the agonist when you compare. So it is an inverse agonist. So inverse agonist will bind to the receptor and produce the opposite action. Is that clear? This is the answer for this. Option B is the answer. So next, moving on to the 16th MCQ, that is, which of the following is true for receptor action of a drug? So antagonist has got both intrinsic activity and affinity for receptor. They're asking about which is the true statement. So when you take a above graph, it will help you in solving this MCQ. So antagonist has got both intrinsic activity. So intrinsic activity is 0. This is ruled out. It has got affinity but no intrinsic activity. Antagonist has got affinity but no intrinsic activity. Yes, it is the correct statement. Partial agonist, it has got no intrinsic activity. It has got some intrinsic activity, 0 to 1. And also it has got the affinity. Intrinsic activity and affinity are not important for drug action. It's very, very important. So the true statement here is the antagonist has got affinity but no intrinsic activity for receptors. So next, moving on to the 17th MCQ, that is, two different chemicals act on the two different receptors. So please remember, very, very important, two different chemicals act on two different receptors, but they have got the opposite response. The response is opposite to each other on the same cell itself, on the same cell. So what is this called as? So please remember, this is called as the physiological antagonism. Physiological antagonism, or the other name for this is the functional antagonism. Functional antagonism. So what are the examples for functional antagonism? It is your histamine and the adrenaline. So what happens with respect to the lungs? It causes bronchoconstriction, it causes bronchodilation. So the one more example again you should remember is, one is the glucagon and the insulin. So what is the effect on the glucose here? It increases the glucose levels. It decreases the glucose levels. It decreases the glucose levels. Is that clear? Okay. What do you understand by a chemical antagonism? Here the chemical, the example is the heparin and its antidote, the protamine sulfate. Protamine sulfate is the example for chemical antagonism. So what is the reversible antagonism? Reversible means you can reverse the antagonism. It is nothing but similar to that of the competitive. For example, if you are plot a drug, for example, this is the you are given a agonist and next you will get antagonist. If you want to produce these similar response, you need to increase the dose of the drug. So what has happened? The dose is, by increasing the dose, you can overcome the antagonism to produce the similar efficacy. So it is called as competitive. What happens in case of non-competitive? In non-competitive, what happens is, even if you increase the dose of a drug, it will going to produce a decrease in the efficacy. So it will not be able to overcome the antagonistic action. So what do you understand by pharmacological antagonism? Pharmacological antagonism or the receptor antagonism. For example, if you take a beta 1 or beta agonist and a beta blocker. What is the effect on the heart? So it will going to stimulate the heart, it will going to increase the heart rate, it will going to block the B1 receptor and it will going to decrease the heart rate. They are acting on the receptors. So next, coming to the SLE-like reactions. So SLE-like reactions is caused by which of the following drugs? So SLE-like reactions are produced by the ship drugs which undergoes acetylation. One is the sulfonamides, sulfonamides, you have hydralazine, you have INH, and P stands for your procainamide. So SLE reaction is seen with which of the following drugs? Ship drugs. So it is your hydralazine. Hydralazine is the drug which is producing SLE-like reactions. So usually the rifampicin, what they are going to ask is, it will going to produce it is an anti-tubercular drug. It will going to produce a reddish or orange discoloration, body discoloration. So paracetamol, as you know, paracetamol many times they are going to ask about the antidote. It is your N-acetylcysteine. N-acetylcysteine is the antidote. Furosemide is a loop diuretics. It is an example for eye sealing diuretics. So usually it is used in the treatment of anasarca, generalized edema. So next, coming to the 19th question, that is the study of how variation in human genome affect the response of medication is known as. Already we have known that it is a pharmacogenomics. So but this definition is actually pharmacogenetics, but in your exams they have asked about, given the option genomics, the closest option for this question will be your pharmacogenomics. So you need to select the closest or the appropriate answer. So pharmacokinetics is mainly deals with the ADME. It deals with the absorption. A stands for absorption, D stands for distribution, M stands for metabolism, and E stands for excretion or the elimination. So pharmacotherapeutics is mainly deals with the drug which are used for clinical use to benefit the patient, to particularly in benefiting a particular diseases. So what do you understand pharmacovigilance? It is a science or the art which deals with the prevention. So you need to remember this mnemonic, DAUP. It deals with the detection, assessment. U stands for understanding, and P stands for prevention of adverse drug reactions. Please remember, pharmacovigilance means you are keeping an eye on the adverse drug reactions. So next, moving on to the 20th question, that is your U-shaped dose response curve. So usually what you get is the normal dose response curve is the rectangular hyperbola, whereas the log dose of DRC, it is your sigmoid curve, whereas the U-shaped curve is a unique dose response curve for vitamins. Please remember, it is the unique dose response curve for vitamins. So next we have a 21st question, that is, in which of the following phases of clinical trials the healthy normal human volunteers will participate? So as you know, the phase 1, all this clinical phase 1, 2, 3, 4 are done in humans. It is the human clinical trials. So it is done in healthy volunteers. This is done in patients. Again, this is phase 3 is done in patients, and again phase 4 is also patient. So what will be the difference here? The number of the participant. Here the healthy volunteers will be small in number. Here around it will be around 50 to 100. Again in phase 3 you are going to choose a larger population, 500 to some 5000, and this will be the larger population. So basically here in phase 1 you are going to check for the dose limit, you will check for the safety profile, and again this is the first stage in the patient, that is phase 2. Again you are going to explore the safety. This is also called as therapeutic exploration. So again this is done in, again you will be checking for the safety. So this difference is, this is done in a single centric. This is done in multiple center, it is multicentric, and this is also called as therapeutic confirmation. And this is the larger population. You're going to check for any rare adverse effects or any new indication, and since if you are not tested on the extremes of age group, in case of children's or in case of elderly or in case of pregnancy, you'll come to know the effect on these populations in the phase 4. So before that we have a preclinical trial. So what do you understand by preclinical trial? So this is done in animals. So once the animal study is approved, you'll going for a phase 1 trial, and before going to phase 1 trial, so very important question that we'll ask is, you're going to apply for investigational new drug. Please remember, you're going to apply for investigational new drug application. So investigation new drug is application is applied after preclinical trial but before the phase 1. So after phase 3, before going to the phase 4, you're going to apply for new drug application, NDA, new drug application. So it is only after the confirmation of the safety in the larger population in the phase 3, you're going to apply for the new drug application just before phase 4, that is after the phase 3. Sometimes what will you do is, before taking the a study into the phase 1, you're going to do the, what you're going to do? You're going to do the phase 0. It is also called as microdosing study. So basically you're going to check for the pharmacokinetic parameters. If it is favorable, you're going to continue. If it is not favorable, you're going to stop it here. So it is not favorable, you're going to stop, so that you can save the human manpower as well as the cost which is involved in the clinical trials. Is that clear? So here the option is, they are done in healthy volunteers. In case of the 0 microdosing study, you will select some 10 to 15 individuals, that's all, 5 to 10 to 15 individuals. So the clinical trials which involves the healthy normal human volunteers, here the answer is the phase 1. Is that clear? Okay. So sometimes the phase 4 is also called as post marketing surveillance. Sometimes it is also called as pharmacovigilance. It's a part of pharmacovigilance. Okay. Next, moving on to the 22nd question, that is, for which of the following drugs a warning is written to be sold by a retailer on prescription of a registered medical practitioner only? So here it is the direct question, very important. So as you can see, this is the direct answer, Schedule H. So all the Schedule H drug requires prescription. It requires prescription. So So what is Schedule X drugs? This is for psychotropic drugs. What is Schedule Y drugs? It is related to the clinical trials. So please do not confuse. What is Category X? Category X is mainly deals in case of pregnancy. They are categorized into category A, B, C and X. X is mainly for the teratogenic causing drugs. Category X. So this you should remember. So which of the following drug is excreted in saliva? So you need to remember three drugs: L, I, R. L stands for your lithium, I stands for iodine, R stands for your rifampicin. So here the answer is excreted through saliva. It is your lithium. Next, moving on to the next question, that is the drugs which are used for rare diseases, also known as, it is the orphan drugs. What happens? The drug manufacturer will manufacture a drug. Let us say drug A. This is the orphan drug. And when it is released into the market, what happens? There will be loss, because they will not be able to get whatever the money which are spent on the clinical trial in producing these drugs. So what has happened is, in the meantime, the countries have provided some subsidy to manufacture this so that there won't be any loss. So one such example is your very important drug, that is N-acetyl cysteine, which is an antidote for paracetamol poisoning. So this is the example for the orphan drugs. Is that clear? The drug which is used for rare diseases where the company cannot recover the amount of drug which is spent on the research. So when they are marketed, there will be loss. So that's why they are giving a subsidy. So these are called as orphan drugs. Over-the-counter drugs means the over-the-counter drugs, they will be given without prescription. So all the following drugs are teratogenic except. So the next question, the 25th, all the following drugs are teratogenic in nature except. Again, please remember, you must make a note of exception in the question. So alcoholic can cause alcohol fetal syndrome. Phenytoin can cause fetal identoin syndrome. This is teratogenic. This is also teratogenic. Warfarin can cause warfarin fetal syndrome. So only the left out answer here is, that is not teratogenic, is the right answer is metoclopramide. Metoclopramide is a prokinetic agent. Mainly it is used to prevent the vomiting. But only limiting factor for use of the metoclopramide is the adverse effect. It has got extrapyramidal side effects. So similarly, which can be used in case of the Parkinson's disease to prevent the vomiting, you cannot use metoclopramide because it causes extrapyramidal symptoms. So you will going to prefer the domperidone. Domperidone is preferred, which is a peripherally acting D2 blocker. It will not cross the blood-brain barrier and there is no extrapyramidal side effects also. Why extrapyramidal side effects? It crosses the blood-brain barrier. It crosses the CNS blood-brain barrier. So, okay. Next we'll move on to the 26th MCQ, that is essential medicines or those medicines. So essential medicines are those medicines that are needed to treat the emergency conditions, that are needed to treat the serious diseases, that satisfy the healthcare priority needs of the population, and there should be introduced recently into the market. So here, this is not a definition. This is not the definition of essential medicine, and this is not. Here, the proper statement which relates with the essential medicine is it is an essential medicine that satisfy the healthcare priority needs. Healthcare priority needs in terms of safety, in terms of accessibility, and you have need, and it should be essential. It should be essential to that area. So it should be in terms of measuring the safety. It should be safe, it should be accessible, it should be need, and it should be essential. So then it will be called as an essential medicine. So next, coming to the 27th MCQ, that is a synaptic transmission in autonomic ganglion is usually. Again, a very important MCQ and very easy at all the synaptic. So this is the spinal cord. So usually this will be the parasympathetic, sacrocranial, and thoracolumbar will be the sympathetic. So usually this will be having longer preganglionic, shorter postganglionic, and this will be having sympathetic will be having shorter preganglionic and longer postganglionic. So all this ganglionic site. So what will be the release? Acetylcholine. So here the synaptic transmission in the autonomic ganglion is usually, answer is direct, it is cholinergic. So next, moving on to the 28th MCQ, that is, which of the following anti-glaucoma medication is unsafe in infants? So please remember, they are asking which is the anti-glaucoma drug which is unsafe in infants. Please remember, it is your brimonidine. So brimonidine, being a alpha agonist, they are the derivatives of the adrenaline, so they will cause sleep apnea in case of children's, because it causes CNS depression. So that is why they are contraindicated in infants. Timolol is a beta blocker. Latanoprost is a prostaglandin, F2 alpha analog, and the dorzolamide. Dorzolamide is also the acetazolamide group of drug, which is nothing but the carbonic anhydrase inhibitors. So this usually latanoprost will going to cause iris pigmentation as a side effect. Iris pigmentation, heterochromia, pigmentation. Sometimes it can cause macular edema, eyelash growth of eyelashes. So I need to remember this. So next, moving on to the 29th question, that is, a patient complains of muscle weakness. It was reversed on the administration of neostigmine. So neostigmine is what is neostigmine? It is a anticholine esterases. So what do you understand by anticholine esterases? So it block the activity of acetylcholinesterase activity, thereby it increases the acetylcholine level. So by increasing acetylcholine level, you can increase the muscle power. So it interferes with the action of the acetylcholinesterase. The correct option here is the D, that is it interferes with the acetylcholine esterases. So carbonic anhydrous means it is your acetazolamide, which is a diuretic as well as it is an anti-glaucoma drug. So please don't confuse. It will not block the action of acetylcholine. So it will increase the action of acetylcholine. So it only block the or interfere with the action of the acetylcholine esterase. Next, moving on to the 30th MCQ. Neostigmine is not able to cross the blood-brain barrier. What is the reason? So please remember, neostigmine is a quaternary compound. So the quaternary compound cannot cross the blood-brain barrier. So it is the tertiary compound which can easily cross the blood-brain barrier like physostigmine, pyridostigmine can cross the blood-brain barrier, but not the neostigmine. So where do we use neostigmine? Neostigmine can be used in case of myasthenia gravis. Pyridostigmine can be used. So what is the difference between pyrido and neostigmine? Pyridostigmine is longer acting drug. This you should remember. Next, coming to the 31st MCQ, that is all are cholinergic agent except. So galantamine is used, donepezil is used, tacremine is used, again the memantine is used. But here the important trick is the galantamine, donepezil, tacrine, all they belong to cholinergic agent. This is the memantine is the NMDA receptor antagonist. Memantine. So this is the answer. So the answer is memantine. Next, moving on to the next MCQ, that is the 32nd MCQ, that is organophosphates binds to. So if you take as the acetylcholine esterase enzyme, so I have got two sites here actually. One is the esteric site, one is the anionic site. So the organophosphorus compound will bind to the esteric site, and this will be the anionic site this will be the vacant one. So this will be available for atropine to bind in case of organophosphorus compound poisoning. Organophosphates binds to which compound? So please remember, it binds to the esteric site. The anionic site is bound by the atropine. So whereas in case of carbamate, what happens? Carbamate poisoning. So in case of this, carbamate will bind to both the esteric site as well as the anionic site. So therefore atropine is not effective here. Atropine will be effective. The only thing is here the oximes can bind to the anionic site. So here the oximes it is. It is your oximes. So the oxime binds to the anionic site and it will remove the OP compound. Whereas oximes here, it is not effective. Why it is not effective? Because already the carbamate has already bound to this sites. So there is no vacant site. So the oximes are not effective in case of carbamate poisoning. So here the answer for organophosphate bind to the esteric site of the acetylcholinesterase enzyme. So it prevents the aging of the enzyme, So we have pralidoxime, etc. We have oxime. What is the example? We have pralidoxime, obidoxime, etc. Next we have a drugs used in the ameliorative therapy test, for myasthenia gravis. So this is also called as tensilon test. Other name for tensilon test is the edrophonium test, which will differentiate the myasthenic crisis from cholinergic crisis. So when you give a edrophonium, so why edrophonium is chosen? Edrophonium is what is the reason? It is shorter acting drug. It is short acting. So when you give, if there is a myasthenic crisis and cholinergic crisis, so after giving, there will be, what happens in cholinergic crisis, there will be decrease in the acetylcholine. So edrophonium will going to increase the acetylcholine, and what will happen? There will be improvement in the muscle. So cholinergic crisis means already there is a increased acetylcholine. Apart from that, on that you are giving edrophonium, again it will going to increase the acetylcholine. It will going to cause worsens the muscle weakness. So here the tensilon test is the other name for edrophonium test, and myasthenia gravis is used to the edrophonium is used for the diagnosis of myasthenic crisis over the cholinergic crisis. Is that clear? Fine. Next, moving on to the 34th MCQ, that is, which anti-glaucoma drug can be used in an asthmatic? Anti-glaucoma. So usually in asthma, the beta blockers, especially the non-selective beta blockers, are contraindicated. So timolol is contraindicated, bitoxolol is propranolol is contraindicated, and it is the bitoxolol which is the selective beta 1 blocker. So this can be used, or it can be preferred in case of asthmatics. So next, coming to the 35th MCQ. Which of the following is the most reliable clinical endpoint to indicates the adequate atropinization in case of organophosphate compound poison? So here the answer is, it is your dilatation of the pupillary dilatation, that is your mydriasis. So please remember, it is the pupillary dilatation which is the end point for the sign of atropinization. So when you see the pupillary dilatation, you need to stop the atropine. So mydriasis can be of two types. One is the passive type, another one is the active type. This passive, the example is the atropine. The active one is the phenylephrine. What happens to the cycloplegia? With respect to atropine and with respect to phenylephrine. Cycloplegia is absent here. Cycloplegia is present with atropine. And this is the longest acting. And there is one more passive, that is tropicamide, which is the shortest acting drug, and this will be the longest acting drug. So this you should remember. Next, moving on to the 36th MCQ, that is, a pilocarpine reduces intraocular pressure in persons with closed angle glaucoma. By how it is reduced? So please remember, there is a mnemonic which reduces the aqueous humor secretion, which increases the uveoscleral outflow, which increases the trabecular outflow. So here you need to remember for this A, B, C. A stands for the adrenaline group of drugs, adrenergic group of drugs. B stands for your beta blockers. C stands for carbonic anhydrase inhibitors. Whereas on the other hand, the drugs which are increasing the uveoscleral outflow is A and B. A stands for again the adrenergic group of drugs, and here P stands for prostaglandins. So here drugs which are increasing the trabecular outflow, it is your A, M, P. This is the prostaglandins. This is your adrenergic group of drugs, and here comes the twist. It is your meiotic. So which is the meiotic? It is your pilocarpine. So it increases the outflow. Which outflow? Trabecular outflow, which is the nearest option here. So it increases the aqueous humor outflow. Aqueous humor outflow. Pilocarpine, it is the aqueous humor outflow. Please remember, it is available in the form of Accusert. Accusert, a newer drug delivery system which is kept in below the eyelid, and it will act for nearly 1 week. It is slowly released constantly from the eyelid through Accusert. Is that clear? Fine. Okay, next coming to the 37th MCQ, that is sweating as a result of exertion is mediated by. So please remember, all the secretions are mediated by all secretory activity. Secretory activity is mediated by parasympathetic nervous system, except for sweating, which is mediated by sympathetic cholinergic fibers. So sweating as a result of exertion is mediated by sympathetic cholinergic fibers is the answer. Is that clear? Fine. We'll move on to the next MCQ, that is the 38th MCQ. So which of the following anti-glaucoma drug can cause heterochromia? So as we discussed earlier, heterochromia, iris pigmentation, was caused by prostaglandin F2 alpha. Which is the prostaglandin F2 alpha? That is your latanoprost. Latanoprost is also the first line drug for treating glaucoma. So the answer will be your latanoprost. Aprachloride, sometimes there will be a lid retraction as a side effect. So here iris pigmentation, it is your latanoprost is given in the form of eye drops. Next, moving on to the 39th MCQ, that is your botulinum toxin blocks the neuromuscular transmission by which of the following mechanism? So this is the neurotransmitter. So if you draw this, the release of acetylcholine will be blocked by botulinum toxin, and which blocks the entry of the acetylcholine into vesicle? Vesamicol is the one which inhibits the entry of the acetylcholine into the vesicles. Vesamicol. Release is by the botulinum toxin. And here the mechanism is, it closes the calcium channel at the presynaptic membrane. So answer is a closure of calcium channel at presynaptic membrane. It will lead to block in the release of the acetylcholine. Is that clear? Fine. So which of the following drug, the 40th MCQ, So we'll move little bit faster. So which of the following drug is used in prophylaxis of motion sickness? So they're asking the prophylaxis. So there are two things here, prophylaxis and the treatment. Prophylaxis, you use the scopolamine, and your treatment you can use promethazine. Other drugs, even promethazine can also be used in the form of prophylactically also for oral use. Scopolamine in the form of transdermal patches. They are used in the form of transdermal patches. So the other name for scopolamine is nothing but the hyoscine. It is your hyoscine is the scopolamine. So here the answer is your hyoscine, which is applied behind the mastoid process, pinna. So next, coming to the which of the 41st MCQ, which of the following drugs has no cycloplegic action? So as we discussed earlier, when we discussed about the mydriasis. So what we discussed? So there was a passive one, there was an active one, active mydriasis. The example was here atropine. And again, you can give an example of atropine derivatives like cyclopentolate, and you have a tropicamide, and the active one is the phenylephrine. So all these drugs will going to cause cycloplegia. Because it blocks the M3 receptors on the ciliary body. Here it is, there is no cycloplegia. So here they are asking no cycloplegia. So the direct answer is your phenylephrine. Is that clear? Okay. Next question, moving on to the retinoscopy in 5-year-old is best done with. Retinoscopy in 5-year-old is best done with. In case of children, there will be high ciliary tone. To overcome this tone, you need to use which drug? You need to use the atropine. So here the drug of choice, retinoscopy in 5-year-old in children, it is atropine. It is your atropine. So atropine is used in children's, but they are contraindicated or avoided in case of adult, especially the elderly. So why? If it is used, there will be dilatation of pupil, and this dilatation of pupil will remain for nearly 7 to 10 days. So there will be a blurring of vision, which is not acceptable for so longer time, because atropine is a longer acting agent. That's why they are avoided in case of fundoscopy in case of the elderly individuals. Is that clear? Fine. Next, moving on to the 43rd MCQ, that is atropine is added to commercial preparation containing diphenoxylate. So diphenoxylate, loperamide, all these are the opioid group of drugs. So usually these are more prone for abuse. So to prevent the abuse, you will be adding the atropine. It will produce us the side effects of dryness of the mouth, urinary retention, decrease in the defecation, etc. So basically the atropine is added for diphenoxylate to prevent the overdose and to discourage the opioid dependence. So this is the correct answer here. Is that clear? Okay. So this loperamide and diphenoxylate are the antidiarrheal drugs which are used for non-infective conditions only. Non-infective conditions. Is it clear? Fine. Okay. Next, coming to the drug that is contraindicated in angle closure glaucoma. Please remember what happens in case of the angle closure glaucoma. So this is the lens. So this will be your, sorry. Okay, this will be your iris. This will be the iridocorneal angle. This is the iridocorneal angle. This is the iridocorneal angle. So this is the iris. So when you give atropine, what will happen? The iris will become dilated. This iris will become dilated. The aperture will increase, and since it is driven towards the iridocorneal angle, this angle will be blocked. Iridocorneal angle will be blocked, thereby it increases the intraocular pressure. So why there is intraocular pressure? There will be increase in the buildup of the aqueous humor. There is no outflow, only to drain the aqueous humor. So what happens? There is an increase in the intraocular pressure. This can lead to blindness also. This can lead to blindness if it is not treated. So that's why the drug which is contraindicated in the angle closure glaucoma is your atropine. Pilocarpine, it produces the meiosis. Dorzolamide, again it is a carbonic anhydrase inhibitor. It is used in glaucoma to decrease the intraocular pressure. Timolol, again a beta blocker. Again they are preferred, and this is contraindicated. Is that clear? Fine. So next, coming to the 45th MCQ, that is dopamine. Dopamine is preferred in treatment of shock because, so dopamine has got a very three important dose dependent action. One is at the D1, followed by beta 1, followed by alpha 1. So this is the 1 to 2 microgram per kg per minute. This is 2 to 10, and this is more than 10. So D1, what it produces? There will be vasodilation of the splanchnic, mesenteric, and the renal blood vessels. So this will lead to increase in the heart rate, and this will lead to increase in the blood pressure due to the vasoconstriction. So this is at the low dose, this is the moderate dose, and this is the high dose or very high dose. So usually you're going to choose these two doses, low and moderate dose, in case of shock. So in case of shock, it will going to cause renal vasodilatory effect, thereby it prevents the renal collapse. So option here is dopamine treatment is preferred mainly to renal vasodilatory effect. Is that clear? Fine. So next, coming to the 46th MCQ, that is all or side effects of salbutamol. Salbutamol is a beta 2 agonist. Where it is used? It is used in the acute treatment of acute attack of bronchial asthma. They are used in the acute attack of bronchial asthma. So usually it produces it produces tremors, it produces tachycardia, it produces T wave changes. There will be hypokalemia. Sometimes there can be palpitation, etc. So you can see palpitation, tremors, hypokalemia, but not the sedation. So they are asking about the exception. The answer here is the sedation is not seen with the salbutamol. Next, moving on to the 47th MCQ, that is epinephrine is useful in. So please remember, epinephrine is the other name for adrenaline. So where do we use adrenaline? Adrenaline is a drug of choice for anaphylaxis or anaphylactic reactions or anaphylactic shock, it is given through preferred route is IM. It is given 0.3 to 0.5 ml in the dilution of 1:1000. If it is the cardiac arrest case, you can use in the ratio of 1:10,000. If it is to be used along with the local anesthetic, the dose has to be diluted 1:50,000 to 1:2 lakh it has to be used. So here the answer is epinephrine is most useful in the treatment of anaphylactic shock. Anaphylactic shock. Is that clear? Even it will going to relieve bronchial asthma. I'm not telling it will not going to relieve bronchial asthma. It will relieve, but the better drugs are available for bronchial asthma. Peripheral vascular diseases, you have better drugs like calcium channel blockers to treat Raynaud's disease. Wide angle glaucoma or open angle glaucoma, you have got the better drugs and surgeries. So epinephrine is used for emergency conditions. So next, coming to the biphasic reaction. So the biphasic reaction on blood pressure is seen with. So what do you understand by biphasic reaction? So when you plot a graph, this is the blood pressure. So this is the baseline. So you'll get a graph like this. So this is the alpha mediated action, alpha 1, and this is the beta 2 mediated. So at the larger doses, it has got high affinity towards alpha 1. In the lower doses, when the dose decreases, it has got affinity towards the beta 2. It is producing the vasoconstriction. This is producing the vasodilation. So this corresponds to the systolic blood pressure, and this corresponds to the diastolic blood pressure. So this is called as biphasic reaction, which is seen with the adrenaline. So it acts on alpha 1, alpha 2, beta 1, beta 2, as well as weak beta 3. Is that clear? It is only beta 1. It is D1, beta 1, alpha 1, and is exclusively alpha, predominantly alpha, and no beta 2 action. Is that clear? So here the best answer is biphasic reaction is seen with the adrenaline. Next, the 49th MCQ. We are nearing to the off century. So let us keep this josh and let us hope for the better marks in your exams. So please concentrate, focus. Okay, next, coming to the 49th MCQ, that is the mechanism of action of clonidine is mediated by which of the following? So clonidine is a centrally acting sympatholytic agent. It is a central sympatholytic agent. So it acts on the which receptors? It acts on alpha 2 receptors. It decreases the sympathetic outflow. So if you take a presynaptic nerve terminals and the postsynaptic, there are alpha 2 receptors in the presynaptic. So this clonidine will going to act. So this is the inhibitory one, and this will going to decrease the release of noradrenaline. So thereby it decreases the sympathetic outflow. Is that clear? Fine. So next, coming to the 50th question, that is stimulation of which of the following receptors will release renin. So please remember, renin are produced by the, so this is the nephron. So there is a JG cells. Stimulation of this by the beta 1 receptor is present. Stimulation of this will going to release the renin. So here the answer will be your beta 1. Is that clear? Okay. So where does beta 1 is located? So beta 1 is located, apart from that, beta 1 is located in the heart. Where is beta 2 located? Beta 2 is located in the Please don't confuse this. Beta 2, two lungs, only one heart, two lungs, right and left. So beta 2. So next, moving on to the 51st MCQ, that is tachyphylaxis. Tachyphylaxis means fast protection. So meaning is fast protection. So which is the drug which is showing fast protection? It is also called as acute tolerance. The other name is the acute tolerance. So here you have a example for indirectly acting sympathomimetic agents. Indirectly acting sympathomimetic agents will be the example for tachyphylaxis. So which is the drug? We have a ephedrine, we have got tyramine, we have got nicotine, etc. Here the example will be your what is the example? It is your ephedrine. Ephedrine is the example for tachyphylaxis. Is that clear? So tachyphylaxis is not seen clinically, and it is mainly seen in clinical trials, in control setup. So which is the most commonly seen in case of clinically? Clinically, most commonly you are going to see tolerance. Is that clear? Tolerance. Next, moving on to the 52nd MCQ, that is the mydriatic which do not cause cycloplegia. Mydriatic which do not cause cycloplegia. Again, a repeated one. Please remember, tropicamide, it causes mydriasis, but there is a cycloplegia. It causes mydriasis, again it causes cycloplegia. Omotropin, again a atropine derivative, mydriasis, cycloplegia. It is the phenylephrine, it causes mydriasis but no cycloplegia. So apart from that, you need to remember it is a passive meiosis. It is also passive meiosis, and this one is the active meiosis. So the answer is the drug, mydriatic drug which does not cause cycloplegia is phenylephrine. Is that clear? Fine. Next we'll move on to the 53rd MCQ, that is a drug of choice for attention deficit hyperactivity disorder, ADHD. So the drug of choice here is, please remember, it is methylphenidate. Methylphenidate is the drug of choice for ADHD, especially which is seen in the children's. So next we have a 54th MCQ, that is the drug used for the treatment of scorpion sting. So what do you understand by scorpion sting treatment? So here what happens is, in scorpion sting there will be constriction, vasoconstriction, there will be increased in the blood pressure which can lead to hypertension, etc. So you need to give a alpha blocker. Which is the alpha blocker here? So this is the alpha agonist. So this is the morphine, is the opioid group of drug. Captopril is the ACE inhibitor. This is the alpha blocker. So the drug of choice here is the prazosin, which is used in the treatment of scorpion sting. Please remember this. Next, coming to the 55th MCQ, that is propranolol can be used in all of the following condition except. So please remember, propranolol can be used in all. It can be used in thyrotoxicosis. It prevents the conversion of T4 to T3. It is used in the prophylaxis of migraine, and again it is used in the treatment of the hypertension. The here answer is variant angina. So what happens in case of variant angina? This propranolol is a non-selective beta blocker. What do you understand by non-selective beta blocker? It will going to block beta 1 activity as well as beta 2 activity. So beta 2 is required for vasodilation. So in the blood vessel you have got beta 2 and the alpha 1. If it is blocked, the vasodilation is blocked. So what happens? This activity will increase and it will going to cause vasospasm, vasoconstriction, vasospasm. So variant angina is also called as vasospastic angina or Prinzmetal's angina. So this will going to worsen the variant angina. So that's why the propranolol is contraindicated in case of variant angina, or beta blocker or contraindicated in case of variant angina. Is that clear? Fine. Next, moving on to the 56th MCQ. 56th MCQ, that is propranolol is contraindicated in diabetes mellitus because. So why it is contraindicated in diabetes mellitus? Please remember, in case of diabetes mellitus, if there is a hypoglycemia, so what will happen? What are the signs you are going to encounter? There will be sweating, there will be tremor, there will be palpitation, etc. Sweating, tremor, palpitation, and there will be tachycardia. So if you give a propranolol, what will happen? It will going to mask the hypoglycemic symptoms. So what are the symptoms? Tremor, palpitation, tachycardia. It will going to mask the symptoms of hypoglycemia. So patient will not be aware of the hypoglycemic symptoms at all. So that's why the answer is they're contraindicated in diabetes because it masks the hypoglycemic symptoms. In other questions they will ask except for. It will not mask the symptoms of sweating. What is the reason? It is mainly mediated by sympathetic cholinergic fibers. So whereas all these are mediated by sympathetic activity, sympathetic stimulation, tremor, palpitation and tachycardia. It is due to sympathetic activity, so thereby can be blocked by propranolol, but not the sweating. Is that clear? But not the sweating. So next, moving on to the 57th MCQ. So which of the following alpha blocker drug is used in the treatment of benign hypertrophy of prostate without producing? Please remember, alpha blocker, treatment of benign hypertrophy of prostate without producing any significant hypotension. So it is your tamsulosin. Please remember tamsulosin. So if the patient has got BPH plus hypertension, so you need to go with the terazosin. If the BPH without hypertension, you need to go with the tamsulosin, which is a alpha blocker, alpha 1A blocker. Is that clear? Fine. Phentolamine is used in case of the clonidine withdrawal symptoms, etc. And also in case of pheochromocytoma. Next, coming to the 58th MCQ, that is beta blocker having both alpha and the beta blocking property. So these are the third generation beta blockers. So we have a carvedilol, which has got both alpha blocking as well as beta blocking. Other example is the labetalol. Labetalol is the example for the both alpha and beta blocking activity. Is that clear? Okay, fine. And this carvedilol is one of the preferred drug in the treatment of the CHF. And next, coming to the, and this sotalol has got both class 2 and class 3 antiarrhythmic property. Please remember, antiarrhythmic property. Next, we have a 59th question, that is a beta blocker having an intrinsic sympathetic activity is. So beta blocker with intrinsic sympathetic activity is your pindolol. Please remember pindolol. Pindolol. Partial activity. It is your pindolol, alpranolol, you have got acebutolol, etc. Acebutolol, etc. So these are some of the examples for the beta blocker with intrinsic sympathomimetic activity: pindolol, alpranolol, acebutolol, and you also have the celiprolol. Celiprolol contains partial agonistic activity. You can remember partial agonistic activity. Is that clear? Fine. Next, moving on to the 60th MCQ, that is the ideal drug which is employed in the preoperative preparation for surgical excision of pheochromocytoma. So pheochromocytoma is the adrenal tumor where there will be increased in the catecholamine release, and this will lead to increase in the noradrenaline. This will further lead to increased vasoconstriction, and there will be increase in the blood pressure. So this will lead to hypertensive crisis. So what happens is, in the treatment or before surgery, you need to give initially you need to go with the alpha blockers, followed by the second is the beta blockers, not the opposite. If you give a beta blockers first, there will be increased activity of alpha and it will lead to hypertensive crisis. So that's why first you give alpha blockers. So thereby, even if you give a beta blocker, there won't be any alpha activity. There will be no unopposed action of the alpha mediated vasoconstriction. So here the drug will be your phenoxybenzamine. Phenoxybenzamine is the ideal drug which is given preoperatively to prevent the alpha mediated vasoconstrictive action. Is that clear? Fine. Next, moving on to the 61st MCQ, that is a beta blocker are contraindicated in. Please remember, beta blocker are contraindicated in asthma, in case of bradycardia, in case of block, which block? AV block. In case of CHF, especially in case of acute CHF, in case of decompensated, they are contraindicated, and D is for diabetes mellitus. But beta blocker can be used in case of chronic CHF. Please remember, chronic CHF, and this is example is your carvedilol, and this will going to decrease the mortality, thereby it is going to increase the longevity of the individuals, as well as these drug in chronic CSF will going to prevent the cardiac remodeling, Is that clear? So beta blocker are not indicated in, so they can be used in arrhythmia, they can be used in CHF, they can be used in hypertension, but not in case of the acute CHF. Is that clear? Fine. So next, coming to the 62nd MCQ, that is the drug of choice for bradycardia due to beta blocker overdose. So as we know that if you give a atropine will cause tachycardia. So atropine will be your drug of choice in case of the bradycardia due to beta blocker overdose. Is that clear? All others, why they are not indicated? Because these will going to increase the risk of arrhythmias. So next, coming to the 63rd MCQ, that is propranolol is useful for all of the following except. So again, a very, very important question. Propranolol, it is used in the hypertension, it is used in the anxiety or tremors, it can be used in case of angina, but not in case of variant angina. Please remember, variant angina. But here the contraindicated is AV block. AV block is the correct answer. Propranolol is contraindicated here. Next, coming to the 64th MCQ, that is the beta blocker with peripheral vasodilatory action. So again, a very important drug, that is your carvedilol. Carvedilol has got alpha inhibitory action and beta inhibitory action, and also it will going to release the nitric oxide. Thereby it will produce the vasodilatory action. Vasodilatory action. Is that clear? Fine. Next, coming to the 65th MCQ, that is a hypertensive patient has got heart rate of 50 beats per minute, taking a tablet of atenolol 200 mg per day in a divided dose. After anesthesia, the heart rate further fell down to 40 beats per minute. What will be the appropriate treatment? So since it is causing bradycardia here. So again, what is the treatment for bradycardia? Bradycardia induced by beta blockers. The treatment will be your atropine. You give atropine. This will going to increase the heart rate, tachycardia. So it is your IV atropine will be your drug of choice. Is that clear? Fine. So next, coming to the 66th MCQ, that is a 33-year-old patient with history of asthma is being treated for symptoms of hypertension. The patient is, which of the following beta blocker would be appropriate for the therapy for this patient? So which is the appropriate drug? So asthma is there, beta blocker. So non-selective beta blockers are contraindicated. So this is contraindicated. Isoprenaline, again it will going to increase the risk of hypertension. So this is also contraindicated in this patient. Labetalol, it blocks alpha as well as the beta. It is not specific. So here metoprolol is the cardioselective beta blocker. That means it blocks beta 1 receptors. So this will be a preferred drug in the treatment or in the above patient. That is the metoprolol, which will not have an effect on the asthma. Is that clear? Fine. So next, coming to the non-sedative 67th MCQ, the non-sedative antihistaminics are all except. So non-sedating means they are asking the second generation antihistaminics. So here the second generation, this is second generation. This is also second generation levocetirizine, cinnarizine, sorry. Okay, levocetirizine is second generation, desloratadine is second generation, fexofenadine is second generation. So these are the non-sedative groups, non-sedative, and this is the one which is sedative, and it is first generation. So the answer here is cinnarizine. So what is the difference between the first generation and the second generation antihistaminics? So it has got sedation, no or less sedation. Why? Because it crosses the blood-brain barrier. It do not crosses the blood-brain barrier. It has got anticholinergic action, no anticholinergic action, and it has got anti-adrenergic action. There is no anti-adrenergic action. Is that clear? Fine. Basically these are used in the treatment of the allergic reactions. Next, moving on to the 68th MCQ, that is a drug which blocks both H1 as well as serotonin, that is 5-HT2 receptors. So please remember, here it is the cyproheptadine blocks the both H1 5-HT2 receptors. These are used to increase the appetite, to improve the growth, or to improve the weight in case of children's, mainly to gain weight, So phenoxybenzaimine is the alpha blocker, ondansetron is the 5-HT3 antagonist. Is that clear? Ritonserin is the anti-anxiety drug. Next, coming to the 69th MCQ, that is triptans. Triptans is used in migraine headaches or agonist at which receptors? So please remember, triptans, they are used for acute severe migraines. They mainly act on the 5-HT 1B 1D receptors. So the answer is 5-HT 1B 1D receptors. So next, moving on to the 70th MCQ, that is the drug of choice in acute severe migraine is. So acute severe migraine, the drug of choice will be your sumatriptans. Triptans will be your drug of choice. So this ergot and dihydroergotamine can be used, but there is a increased risk of hypertension. Even sumatriptan, there is a risk, but this risk is contraindicated if the patient is have ischemic heart disease, etc. Propranolol is used for only the prophylaxis purpose. So all of the following, so please remember, for acute severe migraine it is the sumatriptan. So all of the following, 71st question, all of the following can be used for prophylaxis of migraine except for, so topiramate, anti-epileptic drug, is used for prophylaxis. Propranolol is used for prophylaxis. Again, anti-epileptic drug, that is the sodium valproate, is used for prophylaxis, and this is used for treatment. So all of the following is used for prophylaxis except for sumatriptan is the answer. So next, moving into the 72nd MCQ, that is a therapeutic efficacy of antihypertensive drug is blunted by NSAIDs, non-steroidal anti-inflammatory drug. What is the cause? So because NSAIDs can cause two things. So since it blocks COX activity, it will prevent the prostaglandin synthesis. It inhibits prostaglandin synthesis. So thereby it can increase sodium. It increases sodium and water retention. It will also hinder the antihypertensive efficacy. On the other hand, it will also decrease the prostacyclin synthesis. So here the option is, so it increases the clearance of antihypertensive drug. No, this is the wrong answer. Decrease the absorption of antihypertensive drug. Wrong answer. Causes sodium excretion. Actually, it retains the sodium. So this is the wrong answer. And it decreases synthesis of vascular prostacyclin. Yes, this is the correct answer. So therapeutic efficacy of the antihypertensive drugs are blunted by NSAIDs because of the decrease in the synthesis of vascular prostacyclin. This is responsible for vasodilation. Is that clear? Fine. So prostacyclin is required for vasodilation, but decrease in the prostacyclin will cause vasoconstriction. Is that clear? Fine. We'll move on to the next MCQ, that is the 73rd MCQ, that is aspirin should be used with caution in the following group of patient because of which of the following reason. So very important. Let us see the options. In diabetics, because it has got hyperglycemia, no. In children's, in viral disease, because of risk of acute renal failure, no. In case of gout, because it increases the risk of uric acid, yes, this is the Right answer. Next option, in pregnancy it increases the risk of teratogenicity. No. So in case of aspirin at therapeutic dose and the toxic dose. So this will going to increase the uric acid. So it will increase uric acid levels. In case of the toxic doses, it decreases the uric acid levels. It causes the increased excretion. So it has got uricuric action at higher doses. But normally at therapeutic doses, it will retain the uric acid. So in gout, it can increase the risk of uric acid. So this is the answer. So coming to the 74th MCQ, that is, which prostaglandin helps in cervical ripening? So it is your prostaglandin E2, dinoproston will going to cause cervical ripening. F2, it is used carboprost. It is for treatment of postpartum hemorrhage. Prostacyclins, alprostadil. These are mainly used for erectile dysfunctions. Is that clear? Fine. Cervical ripening is done before the induction of pregnancy, induction of labor. So next, coming to the 75th MCQ, that is, N-acetylcysteine reduces the severity of hepatic necrosis and toxicity due to. So N-acetylcysteine is an antidote for a direct question. It is the acetaminophen, which is a paracetamol. So please remember this, paracetamol. This is methyl dopa. So isoniazid will cause peripheral neuritis. To prevent the peripheral neuritis, you need to give a pyridoxine. Is that clear? Vitamin B6 supplementation has to be given. Next, coming to the misoprostol. 76th MCQ, misoprostol. Misoprostol is an analog of, please remember, E2 you have already learned. It is dinoproston. F2 you have already learned carboprost. This is the alprostadil, and this is the misoprostol. So basically they are used, it is a specific drug to treat the NSAIDs induced peptic ulcer is the specific drug. If they ask about the drug of choice for NSAIDs, so what will be your drug of choice? It is your proton pump inhibitor. Please don't confuse. Proton pump inhibitor. Next, coming to the 77th MCQ, that is, which of the following increases the uric acid excretion? So allopurinol is a xanthine oxidase inhibitor. It prevents the uric acid synthesis. So aspirin will going to increase the uric acid levels. So colchicine is used for in case of acute gout, but because of their side effects like kidney, liver and bone marrow toxicity, they are not used. So it is a probenecid, which is a uricosuric agent. So this is the one which increases the uric acid excretion. So probenecid. So whenever we talk about the probenecid, please remember, when probenecid is given along with the penicillin, it competes with the penicillin and it will decrease the secretion of penicillins, and finally it will increase the penicillin concentration, increases the duration of action of penicillins. Okay, here the answer is increase the uric acid excretion, it is your proban acid. So what is the answer for allopurinol potentiates the action of? So allopurinol is a xanthine oxidase inhibitor, and let us see which are the drugs which are the substrates for xanthine oxidase. So here it is the 6-mercaptopurine. So 6-mercaptopurine as well as azathioprine, they are also metabolized by xanthine oxidase. Xanthine oxidase is required for these drugs to get metabolized. So if this is inhibited by the allopurinol, this concentration will go up and it will potentiate the action of 6-mercaptopurine and the azathioprine. So here the correct answer is 6-mercaptopurine. So next, coming to the allopurinol specifically inhibits 79th MCQ, that is allopurinol competitively inhibits the xanthine oxidase. So, and also please remember, allopurinol is a drug of choice for chronic gout. So if they ask about fastest acting uric acid excretors, so what will be your answer? Your answer will be your rasburicase. So this uricase enzyme is not present in human. This will going to convert the allantoin into water soluble forms which get easily excreted. Is that clear? Fine. Rasburicase, pegloticase, etc. Coming to the 80th MCQ, that is, which of the following is the disease modifying anti-rheumatoid drug? So here the option is desferoxamine is a antidote for iron poisoning. Penicillamine is one of the DMRD drugs. Succimer is used in again the arsenic, lead, etc. Again dimercaprol is used in arsenic, lead, mercury, etc. So here the option which is correct to this question is the penicillamine. So which is the drug of choice in disease modifying anti-rheumatoid drugs? It is your methotrexate. So basically it will going to block the dihydrofolate reductase activity, and also they say they inhibit the ICAR enzyme. And whenever you are going to give a methotrexate, please supplement with leucovorin, nothing but the folinic acid supplementation or citrooram factor. So this will going to decrease the folic acid deficiency, thereby further it will decrease the megaloblastic anemia due to methotrexate. Next, coming to the 81st MCQ, that is busenton. So please remember, busenton is the endothelin receptor antagonist. They are used in the treatment of pulmonary hypertension. So I can use other group of drugs also, like sildenafil, tadalafil can also, these are the prostaglandin, phosphodiesterase 5 inhibitor can also be used in case of pulmonary hypertension. So leukotriene modifiers, basically you have Zafir-Lucas, Monter-Lucas, they are the leukotriene inhibitors which are used in bronchial asthma. So next we have which of the following is a venodilator? So hydralazine is an arterial dilator, minoxidil is an arterial dilator, calcium channel blocker is an arterial dilator, and this will going to decrease the afterload. This will going to decrease the afterload. This will going to decrease the afterload. So nitroprusside is both the arteriolar and venodilator. Arteriolar and venodilator. So here the correct option is which of the following is a venodilator? It is here nitroprusside. So next coming to the 83rd MCQ, that is digoxin is contraindicated in. Digoxin is contraindicated. So digoxin can be used in prophylaxis of SVT, atrial fibrillation because of vagomimetic action. It will decrease the conduction from the AV node into the ventricles. They are used in congestive heart failure. It is the only drug which is given orally for treating congestive heart failure, and it is contraindicated in case of hypertrophic obstructive cardiomyopathy. So the right answer is the hypertrophic obstructive cardiomyopathy is contraindicated. Next we have a 84th MCQ, that is which one of the following provides hemodynamic stability and prolongs the survival in case of congestive heart failure. So here they are asking about the drug which decreases the cardiac remodeling and increase the longevity. We have a AC inhibitors, we have ARBs, we have beta blockers, we have spironolactone, then we have hydralazine plus isosorbide dinitrate ISD, and next group is the sacubitril. It is a recombinant neprilysin inhibitor which will going to increase the BNP, brain derived neurotropic factors. So here which one of the following will going to provide a hemodynamic stability and provides the survival in case of congestive heart failure? So not furosemide, not digoxin, mildrenone phosphodiesterase inhibitors, not phosphodiesterase inhibitors. It is your AC inhibitors, that is the lisinopril. Is that clear? Please remember this, very important. So these are the newer inclusions, sacubitril and hydralazine and the isosorbide dinitrate. Next coming to the 85th MCQ, that is all of the following drug reduces afterload except for exception. They are asking exception. So this will reduce the afterload. Hydralazine vasodilator reduces afterload. Sodium nitroprusside reduces afterload. This propranolol will not reduce afterload. So this is the right answer. So since propranolol will block beta 1 as well as beta 2, what happens to the vessels? So there is an increased alpha activity. They are going to cause vasoconstriction and it will going to cause increase in the BP. So it will not contribute to reduction in the afterload. So the answer here is propranolol. So next coming to the mechanism of action of levosomendone. So levosomendone, it is basically a calcium sensitizer to myocardium, and also they are the potassium channel openers which helps in vasodilation. So here the answer is mechanism of action of levosomendone is the potassium channel opener. So which of the following drug decreases plasma renin activity? 87th question. Which of the following drug reduces plasma renin activity? So please remember, it is not the enalapril, it is not the nifedipine, it is not the hydralazine, it is your clonidine. So clonidine is a central sympatholytic drug, thereby it prevents the release of the renin, thereby it decreases the renin activity. So there will be decrease in sympatholytic action. So decrease in sympatholytic action means there will be decrease in the noradrenaline. So noradrenaline decreases means there will be decrease in the beta 1 stimulation in the JJ cells, thereby decrease in the renin activity or renin release. Is that clear? Fine, good. Next, moving on to the 88th MCQ, that is a dobutamine is preferred over dopamine in case of cardiogenic shock. What is the reason? So dobutamine, as you know, it is one of the selective beta 1 blocker it is a selective beta 1 agonist, whereas dopamine, it has got dose dependent action. It acts on dopamine 1, beta 1, alpha 1. So dobutamine has got better cardiac stimulation, it has got lower cardiac risk, it does not have any alpha 1 activity, it can cause more CNS stimulation, but it has got less peripheral vasoconstriction ability. So this is the advantage. So dobutamine is preferred over dopamine in case of cardiogenic shock because it has got less peripheral vasoconstriction, thereby there is a low risk of cardiac arrhythmias and better cardiac stimulation. So it only acts on beta 1, whereas it acts on D1, dopamine 1, beta 1 as well as alpha 1. Although it has got renal vasodilatory effect, it will cause increase in the heart rate here, it will increase in the blood pressure, increase risk of arrhythmias. So that's why dobutamine is preferred in case of cardiogenic shock over the dopamine. It has got less peripheral vasoconstriction. So next, coming to the 89th MCQ, that is all of the following drugs can cause gynecomastia except for. So you should remember DISC. One is the digitalis, digoxin, INH. You have got spironolactone. You have got cimetidine, which is a first generation antihistaminic. Spironolactone is a potassium sparing diuretics. So all these drugs will cause gynecomastia. So digoxin will cause, cimetidine will cause, spironolactone will cause gynecomastia. The exception here is the amiloride. The answer here, it is the amiloride. Next, coming to the which of the following is not a frontline antihypertensive drug. So here the nowadays the drug of choice or the first line antihypertensive drug will be your thiazide group of drug, not the beta blockers. So you can use the hydrochlorothiazide, enalapril as well as amlodipine, but not the atenolol as the first line drug. So beta blockers are not the first line drugs. Please remember, beta blockers are not the first line antihypertensives. So coming to the 91st MCQ, that is the drug not useful in hypertensive emergencies. So you can use hydralazine, vasodilator, IV. You can use sublingual nifedipine. You can use sodium nitroprusside, but not the indapamide. Indapamide is the answer, which is not used in hypertensive emergencies. So it is a thiazide diuretics. Thiazide diuretic, it has got mild diuretic action, and it will have a slow action. That's why it should not preferred in case of emergencies. So drug of choice in case of digitalis induced ventricular arrhythmias, the 92nd MCQ. This is the direct answer. That is, drug of choice for digitalis is IV lignocaine. IV lignocaine is a drug of choice in case of digitalis induced ventricular arrhythmias. So next, coming to the treatment choice, that is the 93rd treatment of choice in hypertensive with diabetes mellitus. So if the patient has got diabetes and hypertension, which will be the drug of choice? Please remember, it is your ACE inhibitors is the drug of choice. It will decrease the proteinuria. In case of diabetes, it protects the kidney. It protects the kidney. It will decrease the kidney damage. So their answer will be your ACE inhibitors. Please remember, very, very important. So next, coming to the 94th MCQ, that is centrally acting antihypertensive drug. Centrally acting, this is the alpha blocker, peripheral acting, propranolol beta blocker. This is alpha blocker. It is a centrally acting drug, methyl dopa. Methyl dopa is the centrally acting antihypertensive drug, and it is also preferred drug during pregnancy, during eclampsias. So nimodipine, calcium channel blocker, where it is used, it is a cerebroprotective drug. Cerebroprotective vasodilator. So it is used in the treatment of subarachnoid hemorrhage. Please remember, nimodipine is used in the subarachnoid hemorrhage. So next, coming to the 96th MCQ, that is glyceryl trinitrate is given sublingual route because. What is the correct option? So where GTN is used, in case of angina, it is used sublingually to bypass first pass metabolism. It directly reaches the systemic circulation for quick action. So what is the correct action? Because it has got high oral bioavailability. Sorry. It is not the answer. It has got high first pass metabolism. So if it had got the high oral bioavailability, it would have used through oral route only. So it has got less oral bioavailability. Because of high first pass metabolism. So that's why they are given through sublingual route. So glyceryl trinitrate mainly will increase the cyclic GMP levels, and one more question they asked is, do not combine with phosphodiesterase 5 inhibitors like sildenafil. It will going to cause hypotension, decrease in blood pressure. So potassium channel opener with anti-anginal activity. Please remember, potassium channel opener with anti-anginal activity, it is your nicorandil. Nicorandil has got potassium channel opening activity with anti-anginal activity. Again, dipyridamole is an anti-anginal drug. Please remember, it causes coronary steal phenomenon. Trimetazidine is a PFOX inhibitor. Again, they are used in the treatment of angina itself. So coming to the 98th MCQ, that is propranolol should not be used in patient on treatment with which of the following drugs. So please remember, propranolol is a beta blocker, non-selective beta blocker. What happens to the heart? It decreases the heart rate, it depresses the heart rate, it depresses the cardiac activity. What happens if you combine with the nifedipine? Nifedipine, again calcium channel blocker, non-dihydropyridines, it will also depress the cardiac activity. So that's why you should not combine with the nifedipine. So you can combine with nitrates, AC inhibitor, and the sorry, here it is verapamil. So you should see the options carefully. Please do not confuse. So it is your verapamil. So nifedipine we can use. Nifedipine is a dihydropyridines which has got predominantly vasodilatory action. That's why you can use in case of along with propranolol. But along with propranolol you cannot use with the verapamil which has got the direct cardiac depressant activity. So the answer here is the verapamil. Is that clear? So please do not confuse. Both are calcium channel blockers, but this is the dihydropyridine, this is the non-dihydropyridine which predominantly acts on the heart than the blood vessels. So here it predominantly acts on the blood vessels than the heart. So coming to the spironolactone, 99th MCQ. Spironolactone, which is a potassium sparing diuretic, should not be given with. So as you know that spironolactone will going to increase the potassium levels. So it should not be given with the other drug which increases potassium levels. So chlorothiazide is a thiazide group of drugs which will not increase the potassium levels. Beta blocker will cause hypokalemia, and again thiazides will cause hypokalemia. Amlodipine will also cause hypokalemia, but here it causes the hyperkalemia. So it is your ACE inhibitors. So do not combine with ACE inhibitors. The example right answer is option C, ACE inhibitors. But you can combine spironolactone with the thiazide. This is allowed because it causes hypokalemia, and this causes hyperkalemia, which is nullified. The side effects will be nullified. So it will have a synergistic action. This will have a synergistic action. So next, coming to the last MCQ, that is your century MCQ, that is the cough is an adverse effect seen with intake of which of the following drug. So cough. So thiazide will not cause dry cough. Nifedipine will not cause cough. Prazosin will not cause. It is your enalapril because of the bradykinin. Bradykinin will going to cause dry cough and the angioedema. So here the answer is your enalapril. So this was about the very important 100 MCQs of pharmacology which has been asked in previous years, and please remember all these MCQ and concepts are very, very important. Please try to get the answer correctly and be cool and try to do as much as possible the previous year MCQs. Please do practice sessions and please do attend the test and discussion session for more clarity. So with this, all the best for your preparations, and we will meet you with the pharmacology test and discussion part 2 MCQ. So till now we have covered the general pharmacology, ANS, as well as we have covered the autocoids. We have covered some of the drugs from the cardiovascular system. In the next class we'll mainly concentrate on the cardiovascular system drugs like the arrhythmias, antiarrhythmic drugs. We'll concentrate on the CNS. We'll concentrate on the antimicrobial agent, chemotherapeutic agent, and other drugs like the drugs used in GIT and in case of respiratory system, etc. So hope you have enjoyed this session. If you have any doubts, you can leave a comment. We'll try to provide a suitable answer as early as possible. Thank you.